All right, everybody get out of my meeting now. Get out. All right. Let me get up in this PowerPoint. Okay. Okay, friends. Okay. All right. So fluids and electrolytes, right? So if you pull out your worksheet, the first couple questions are going to be answered in this first slide. We're talking about fluid and where it resides in the body. If you think about it, every part of your body, every tissue in your body is made up of cells. You need the worksheet? Yeah. Here, I have it on the. There's more. If you mine's already mostly filled out. Oh, okay. So every tissue in your body, every part of your body, the primary unit making up those tissues are cells. So therefore, majority of the fluid inside your body is inside the cells. So the ICF makes up about 2/3 of the intracellular fluid, ICF. Water inside the fluid, inside the cells, makes up about 2/3 of the fluid circulating in your body. Only 1/3 of the fluids in your body is found in the extracellular space, outside of the cells. When we talk about, I hate this room, but all right, when we talk about extracellular fluid, we have fluid inside the blood vessels here. You see a picture of this blood capillary inside the blood vessels. So that's intravascular. And then you have fluid all in between the tissues. That's interstitial. So when you have issues with third spacing, like for example, with ascites, when we were talking about cirrhosis, fluid is leaking out of the capillary bed and in between the tissue spaces. That's interstitial. That's what you call third spacing. So the fluid is no longer in the blood vessel. When we draw blood and we look at labs, are we looking at ICF or ECF? ICF. Now you would have to be some hell of a sharpshooter to be able to stick a needle in somebody's arm and get inside their cells, right? Yeah. Extracellular fluid is what we're looking at when we look at lab values. Extracellular fluid. We're getting blood from the intravascular space, right? Inside the blood vessel, and that is extracellular. You would have to have a microscopic needle to get deep inside the cell and just draw out the amount of fluid that's inside of a cell. So now how to get to the next slide? Come on now. All right. So what do these fluids do? I mean, everyone knows about homeostasis, equilibrium. We're trying to keep balance. Balance is going to be maintained through input and output. It should be equal, right? The amount of fluid we put in should be the amount of fluid we excrete. Thirst, different social factors, personal habits, everything can affect your fluid intake, right? Output occurs in your kidneys. We already talked about the small intestines and how the reabsorption and the large intestine, reabsorption of fluid and electrolytes takes place in the GI tract. Lungs, the lungs also play a part in fluids, and I'll talk about that in a second. And same with skin. Without our skin, everything will just leak out and fall out all over the place, right? Obviously the kidneys are going to be the main regulator when it comes to fluid balance. Fluid losses. When we lose fluid from the lungs and the skin, like sweating, breathing, the evaporated mist that comes out when you're breathing, That's called insensible, or on your worksheet, I believe it says obligatory fluid loss, right? That is not fluid we can measure. There's no way I'm gonna sit with a cup and collect your sweat and measure how much fluid you lost. I could measure your body weight and see what your body weight was prior to and after, and maybe get a rough estimate, but the amount of fluid that comes out from you breathing or you sweating, I can't measure. So hence why a fever would dehydrate somebody, because a fever, you're going to be sweating profusely and you're going to be tachypnic, right? You're going to breathe faster. So you're going to blow off more fluid when you exhale. Sensible fluid loss, obviously that is fluids that you can measure, I's and O's, whether you have vomiting, urine output, stool, if they have a wound vac and you can actually measure the wound drainage. Babies, you can even weigh a wet diaper, okay? That's sensible fluid loss. You can have fluid loss from actual fluid escaping, leaving the body, or not having enough fluid going into the body, but you can also have fluid loss when we talk about ascites, right? If you look at a person with ascites, belly out to here full of fluid, legs swollen to all get out. But guess what? When you look at their labs, they're dehydrated as heck because that fluid is not where it's supposed to be. The fluid is just floating around in a third space, in an interstitial space. So when fluid shifts from out of the cell into the cell and vice versa, that can cause a fluid imbalance. So now let's talk about the different ways that fluids can shift. Osmosis. Osmosis is going to be a shift of fluid from an area of low concentration to an area of high concentration. Basically, it's trying to water that other area down so that they can be equal and balanced. So if you see in the top picture, those are like particles in the water, and the water is moving to the area with more particles in it to help balance out the concentration. Here's some other more realistic examples. If a body, or if you go swimming and you stay in the water, you take a bath, or you stay in the tub too long, what happens is you get bloated, and then when you come out the water, now your skin's all shriveled up. Why? Because that water, some of that water has made its way into your body, because your body is less concentrated than a bathtub of water. Dead bodies, when they find bodies in a river somewhere, not to be graphic, but they're all bloated full of water. That is from osmosis, the shift of the water inside the body to a more concentrated area to help even things out. Snails, I just learned this today or the other day. Snails, if you pour salt on a snail, it can kill them. I'm not from Florida. We don't got snails in Chicago, but I learned today. I'm about to tell my son, we want to go kill some snails. Leeches? Yeah. Oh, okay. Now I know about leeches now. Okay, sprinkle salt on them. Why? Because it's going to suck them dry. The water is going to leave their body via osmosis to try to get to that higher concentrated area where the salt is, right? So everybody understands osmosis, right? So now diffusion. Diffusion is the movement of the particles, the solutes, okay? They're gonna move from an area of I gotta change that. Just know in your mind, it's from high concentration to low concentration. I wrote low and low, I need to change that. High concentration to low concentration. So same thing, the water's trying to balance everything out. The particles are also moving, trying to maintain equilibrium. So for example, you see the color, the food coloring, or like if you make Kool-Aid, initially when you pour the water in, all that sugar and stuff might be at the bottom of the pitcher. But if you left that pitcher sitting long enough, the sugar is slowly going to dissolve and diffuse throughout the fluid to maintain equilibrium. Everybody got diffusion? All right. Other shifts of fluid that happen in the body. So you have hydrostatic pressure. That's the pressure of the liquid or fluid inside the blood vessels. And also there's osmotic pressure inside the cells. It's the pressure of the fluid up against the wall, the membrane, right? Because of that pressure at the capillaries, which are our tiniest little blood vessels, right? At that site is where some fluid and electrolytes get pushed out. And then albumin is a large protein molecule, so it can't get pushed out. So albumin stays inside. It should be inside the vascular bed, drawing some of the fluid back in, called reabsorption. So when your albumin is low, they don't have that. And then they have third spacing. Fluid leaks out of the blood vessels, and then they have tons of swelling. So people with liver failure, for example, only because we just learned about GI, people with liver failure have edema different than people with heart failure. People with heart failure are just fluid overloaded. People with liver failure aren't fluid overloaded, but most of them are malnourished and lacking albumin. They're lacking protein, and thus the fluid does not stay inside the blood vessel walls. We got that? So now let's talk, now that we understand how fluids and particles shift, let's talk about the different types of fluids there are. Isotonic fluids, right? Isotonic fluids are of concentration equal to that of human blood. So when I give you an isotonic fluid IV, it's not going to cause any shifts of fluid. All I'm doing is adding volume to your body. It's not going to cause fluid to shift in or out of the cells. It's just simply adding fluids. Fluids that are isotonic are those three right there. Normal saline, which is 0.9% sodium chloride, that's normal saline. D5 in water only is isotonic. Anything else is hypertonic, but D5 in water only is isotonic. And then lactated ringers, isotonic. So everybody got that? Hypotonic solutions are going to have a lesser concentration than that of the blood, right? Hypotonic, because they are hypotonic and they don't have as much concentration, what they're going to do is force by osmosis fluid to shift into the cells. And I'll show you a picture of that in a second. So fluids are going to go from outside of the cells into the cells when you administer hypotonic solutions. 0.45 normal saline is about the most common. There's another one in your book, 2.5. I've never seen that. There's another one that rarely gets used, like by urologists, and that's 0.25%. But 0.45 probably the only one on your test. 0.45% sodium chloride, or they call it half normal saline. Next, hypertonic solutions. Hypertonic solutions are more concentrated than the blood. So they're going to draw fluid out of the cell, okay, to that higher area of higher concentration. So you usually reserve these people are having, these people are probably, their osmolality is super low. So either they have like super low sodium or something like that. That's usually when you're going to use these, or when the patient is NPO and they require that IV nutrition. Add TPN to this list. I forgot to add it. TPN. So D10, D5 in norm or half normal saline, or D5 in normal saline, and then D50. All those are examples of hypertonic solutions. Here's again a picture of what's going on, right? Osmolarity, when the concentration for isotonic, the first picture is isotonic. What's happening with isotonic solution? The ball is the cell, and this is just your extracellular fluid. So there's no shift, right? Here you see you have cellular edema. The cell got bigger. Why? Because you've administered what kind of fluid? Hypotonic solution. Now fluid is moving from an area of less concentration to more concentrated. Everybody get that? So now you have cellular edema. So this is why infusing hypotonic solutions, for example, can put the person at risk for cerebral edema, swelling in the brain. Low sodium, that's what's going on, okay? High sodium. Low sodium, hypotonic outside of the body. Low sodium is gonna force fluid to go into the cell. And we'll talk about that in a second. And then this one, if the osmolarity, if it is less concentrated in the cell and more concentrated outside of the cell, so if I'm giving hypertonic solution, or if the sodium level outside of the cell is high, it's going to draw fluid out of the cells, dehydrating the cells. And you see this one is smaller than the first one. Everybody understand so far? All right, so electrolytes, what are they? They are electrically charged ions that basically just carry an impulse to the nerve. We have electricity inside our bodies. If this is your first time hearing that, you learned some today, okay? We have electrical impulses inside our body. Signals originate in the brain, and electrolytes help carry those signals from nerves to muscles and, maintain homeostasis, help our body work. They are just like fluids, they're excreted and reabsorbed through the kidneys and the GI tract. You have positively charged ions and you have negatively charged ions. And they also play a role in maintaining fluid balance. Because like I said, fluids are going to shift in and out of your cells based off your sodium level. So electrolytes play a big role in that. They play a role in maintaining acid-base balance, and I'll show you that in a minute. Osmolarity, the term osmolarity means concentration of the blood, and that is highly dependent on your sodium level. Obviously, if your sodium level is high, then your blood is more concentrated. So now let's look at where these electrolytes are. Again, the ball is the cell. The main extracellular electrolyte is sodium. And then you have sodium and chloride. Hence why sodium chloride, normal saline, is the best IV drug that is most comparable or comparable to your extracellular fluid, your blood. When we draw blood from a patient, we are strictly looking at extracellular fluid values. We're not looking at ICS. And then inside the cells, you have potassium, phosphorus, and mag are the main ones, okay? And then calcium and bicarb outside the cell as well. So let's talk about what are each of these electrolytes. Sodium. Sodium, like I said, it's the most abundant electrolyte in the body, sodium, okay? And it is mostly found in extracellular fluid. The main duties of sodium mostly is to maintain fluid balance and osmolarity, okay? They also help transmit signals from nerves to muscles. When you have issues with sodium, the number one thing you're monitoring the patient for, because as we go through, you'll see the symptoms, a lot of them are the same. So trying to memorize confusion when every single possible fluid electrolyte imbalance could cause confusion, it's going to be complicated. But sodium, the main issue you want to monitor for is their neurological status. A person with excess, super high sodium level is at risk for seizures. Same with low sodium level, risk for seizures, confusion. Everything with sodium is going to be neurological. And then what kind of things affect it? Kidney function, urine output. So anything that affects kidney function and urine output, use of diuretics. We'll talk about ADH and aldosterone in a minute, but those are hormones that will affect your sodium levels. So if they're too high, if aldosterone's too high, sodium's going to be too high. If aldosterone is low, sodium's going to be low. ADH, if ADH is high, sodium's going to be low. If ADH is low, sodium's going to be high. GI function, vomiting, diarrhea, your diet. If you're on such a sodium restricted diet, or if you just eat, supersized McDonald's meals every day, your diet's going to affect that. Water intake. There is such thing as water intoxication. Potassium. Potassium is a major electrolyte in the intracellular fluid. The number one thing, and you see it's highlighted there, heart rhythm, heart, myocardial cells are mostly affected by potassium. It does help control osmolality just like the sodium, but the main thing you're going to monitor for with potassium abnormalities is cardiac function. Slight imbalances in potassium could be detrimental to someone's health. Hyper or hypokalemia can cause cardiac arrest. So what sort of things affect potassium? Again, kidney function. Kidneys control a lot when it comes to fluids and electrolytes. Again, GI, a lot of vomiting or excess suction. GI suction is going to lower your potassium. And the same stuff as sodium. The only difference is acid-base balance, and I'll show you why in a sec. Calcium. Calcium's mainly found in the extracellular fluid. Obviously, we know it plays an important role in formation of bones and teeth. It also plays an important role in heart function and blood clotting, coagulating the blood. Main thing with calcium, when we get to it, you're going to monitor for is going to be the excitability of the muscles and tetany. There's two tests that go with calcium and magnesium, Chavostex and Trousseau's. Those are tests you're looking for tetany, which is like muscle hyperflexion, I guess. Hyperactivity, shall I say. Magnesium. Magnesium also plays a huge role in skeletal muscle response. So potassium was cardiac muscle, magnesium is skeletal muscle. So you'll see the sign, when you know what the electrolyte does, then the signs and symptoms will make sense, right? Or the nursing considerations, what are the most important things I need to know as a nurse? Back to those hormones. So these hormones and other mechanisms affect your body's fluid and electrolyte balance. ADH, antidiuretic hormone, is secreted in the brain by the pituitary gland. You don't necessarily need to memorize later. But later, when we do talk about neural stuff, you'll see that a pituitary disorder is going to put somebody at risk for imbalance of sodium because of ADH. ADH, anti-diuretic hormone. Diuresis means you're peeing it out, right? Diuresis, right? Anti-diuresis means you don't want to pee it out, right? So what the secretion that ADH does is it retains water, retains fluid. If you have an excessively high ADH, this is a question. If your ADH is high, what would you expect your urine to look like? Concentrated, exactly, because you're retaining water. So you're putting out this sodium-filled, concentrated thick urine, okay? Because you're holding on to water. So what kind of specific gravity is it going to be, high or low? High. If your urine's concentrated, specific gravity, urine-specific gravity is going to be high. ADH gets released. It's just a natural process that happens when the body knows, dang, my osmolarity is, I'm a little salty. My osmolarity is high. My blood's a little thick. Let me tell my brain, okay, hold on to water so we can balance everything out, right? Aldosterone. Aldosterone is secreted by the adrenal glands. If you've seen a picture of the kidneys, the adrenal glands just sit on top of them like little hats on top of them. And we'll talk about the kidneys next week. Aldosterone tells the body to retain sodium. So a high aldosterone level is going to tell the body to retain high amounts of sodium. Aldosterone is released in response to low blood pressures. So when my body knows, okay, the blood pressure is a little low, it's going to tell the kidneys, hey, kidneys, hold on to sodium. And with salt goes water. They ride together. So hold on to sodium, hold on to water, and help boost my blood pressure up. So if you remember from pharm, a lot of the drugs that are used to treat blood pressure act on the RAA system, renin angiotensin aldosterone system. You don't need to know that right now, but that's why, because they stop that secretion of aldosterone and keep the body from retaining sodium. And then thirst again occurs in the brain. It's just a response to, again, osmolarity is creeping up. I'm getting a little salty. I think I'm thirsty and I need some water. So those are protective defense mechanisms that are happening all the time inside your body. Psych patients, this may come up in mental health. Psych patients, those on antipsychotics and those with schizophrenia can develop a condition called psychogenic polydipsia. For whatever reason, they just drink water incessantly and become, because of it, water intoxicated. It can cause them to have a lot of electrolyte issues. If you've ever worked in a psych ward or you've seen patients like this. You have patients where you gotta damn near place yourself between them and the sink and the water fountain. They can't help it. The medications make them thirsty, then they've got this compulsive thought process. But yeah, it's something, hyponatremia is common in people with schizophrenia and people on antipsychotics. All right, dehydration. Dehydration is caused by lack of fluid volume. Now, it could be from actually losing fluid, actually not taking in enough fluid, or again, it could be from fluid shifting from the extracellular space into the interstitial space, like third spacing, like ascites. Hypovolemia is when you lose both fluids and electrolytes at the same time, equally. But you could also have dehydration from excessive sodium. We'll talk about that in a second. So when you have dehydration, everything's gonna be concentrated. So your H&H will be high. Your BUN is gonna be high. Your urine specific gravity will likely be high. Creatinine will be high, right? And then with this, I mean, the signs and symptoms of dehydration, I think we know most of them, right? Skin tinting, they're going to be tachycardic because they have low volume. The heart's going to beat faster to try to keep that blood pressure up. They're probably not going to have any urine output, very little urine output, oliguria, nausea, vomiting. You got that. You know what it is. Hold up. Let me go back. Was there anything else? I mean, so obviously, you're going to just be focused on rehydrating them and monitoring them for worsening condition, monitoring respiratory, neurological status, yada, yada. Here's some other signs and symptoms. Dry, tacky, mucous membranes. You see granny on the bottom and the baby at the top with the sunken eyes, tinted skin. This picture in the corner is a picture of sunken fontanelles on an infant. And then that poor little baby just looks dry. Okay, I just put him in there. He looked dry. All right, fluid volume excess. This is either I've been drinking too much water because I'm taking all my Haldol for my schizophrenia, or I can't get rid of enough water, like kidney failure or my heart failure, where I can't keep up with the amount of fluid. So again, I mean, you can read this list. It's either overhydration or inability to excrete the fluids appropriately. And then you see that hyperaldosteronism. Why? Because it's going to cause you to retain sodium and thus water. Fluid overload symptoms are actually going to be tachycardia. Tachycardia for both dehydration and hypovolemia. Because tachycardia, because all that fluid is coming back to the heart, so the heart has to pump harder just to keep up with it. So they may even have, when you listen to heart sounds, S1, S2, they may even have a S3. They got to put an extra beat in there just to keep up with all the fluids, okay? Bradycardia is going to be late signs for either one. Bradycardia and dehydration and hypovolemia is because the heart got too tired. Both of them, really. The heart got too tired to keep up. It was working so hard to stay tachycardic, and then it was just like, F this. The fluid's everywhere. I'm over it. I'm going to sleep. All right. Other signs, ascites, third spacing. So ascites, edema, that kind of stuff. Crackles in the lungs. They may have pleural effusions around the lungs. So now with them, everything's going to be diluted. Everything's watered down. So your blood counts may be low, not because you actually bled out, but it's just watered down right now. Osmolarity's low, and you can read the rest, right? All right. Here's some other signs and symptoms. You see pitting edema. Do you guys know what that is in the bottom picture? It's pink frothy sputum, which is a sign of pulmonary edema. Remember, you're going to have third spacing. So fluid's going to go wherever. It's going to get in where it fits in. It's all over the place. So it may go around your lungs and cause pulmonary edema. If it's real bad, you could end up with cerebral edema, swelling on your brain. The fluid is just going to go wherever it can go, okay? Because it can't get out. You couldn't keep up and pee it all out, so now I just got to find somewhere to pee. And this actually is a good picture. I'm going to send you guys this PowerPoint next. All right, so fluid overload. What do I need to do as a nurse? One, monitor respiratory status. Why? Because the fluid's going to be around their lungs. They're going to need maybe a chest x-ray. Monitor the lung sound. Effort, are they having labor breathing? What else? Daily weights. For fluid status, either one daily weights is going to tell you give you a good estimate of is that person losing fluid or gaining more fluid. Monitor edema, low sodium diet, restrict fluids if you need to. Are you gonna lay them flat? No. People with heart failure, people with kidney failure, they have what's called orthopnea. Orthopnea. They get short of breath when they lay flat. They feel like they're drowning. So you're gonna keep them sitting upright. And then the rest, I mean, those are things you do with any patient. Age-related concerns. So remember, older adults and babies, of course, are going to be at higher risk for fluid and electrolyte imbalance. Some of the reasons why: older people, they have a loss of elasticity of their skin is thin, it's easier for fluids to escape. Their kidneys have slowed down because they're just old. If you're 80 years old, your kidneys are 80 years old. So everything's slowing down. They've lost muscle mass. Remember, most of the fluid lives in the intracellular space. Cells are what make up your tissues, muscles, everything. So when you've lost muscle mass, you've lost cells. And then they aren't so quick to get thirsty. Hyponatremia. Things that cause hyponatremia could be an actual loss of sodium, or it could be from dilution. Over the fluid volume excess can cause hyponatremia because everything's watered down. And water moves from outside the cells into the cells because everything's watered down, right? So osmosis is gonna force water into the cells, and hence that's why people end up with cerebral edema with low sodium. Again, sodium, cerebral edema, you're gonna be monitoring neuro, because if you look at these signs and symptoms right here, they're darn near the same for both hypo and hypernatremia. The only difference is body temperature. Labs, I mean, they're right here, less than 136 according to ATI. Your osmolarity is going to be low. Urine specific gravity is going to be low. Everything's watered down. So you're going to teach them about diet, foods that are high in sodium. You're likely not going to administer hypertonic solutions unless it's more severe. 9 times out of 10, you're going to always give isotonic solutions. But if it were a severe case, you may give hypertonic solutions. And then again, restrict fluids, just like we talked about with volume excess. Why are you shaking your head? Is bad?
Oh, no, I'm playing with my mask.
Okay, okay. Let me know if it's too much. How do I end up with this on here? Golly, this stuff goes to the last. No wonder I was wondering where it went. Ignore. I'll change it before I send it to you. This should have went with hyponatremia, right? On the oh God, get me back. This list here. Just know that goes on the other slide. I'll move it. You get what I'm saying? All right. Hypernatremia is going to be from actually losing fluid or not taking in enough fluid or taking in way too much sodium, right? The main difference, I mean, it's going to be the same neurological symptoms. The main thing is hypernatremia. You really want to monitor for seizure activity. They need to be on seizure precautions. Hyperthermia or low, what they call low grade fever is a big one for hypernatremia. What are the labs? You see those there. The main thing is going to be about rehydrating them. they're going to need fluids, maybe even hypotonic fluids or normal saline, but they're going to need fluids, or you're going to encourage them to drink more water. If they're dehydrated because of excessive use of diuretics, then you're going to hold diuretics, things like that. Potassium, obviously you know the levels. Potassium, again, cardiac monitoring. If the patient is admitted for something abnormal with their potassium, you need to monitor, add a cardiac monitor to their care, or an EKG at least. You did? Yeah. And were they monitoring your heart the entire time? Yeah. Yes. EKG changes. If it's in bold, it's probably going to be on your test, okay? EKG changes. You don't need to know how to read an EKG, but you do need to know the changes associated with potassium. So for a low potassium, T waves are going to be almost flat or inverted, and there will be a presence of a U wave. I'll show you pictures in a second. But the U wave, you don't normally have a U wave on your EKG. So if a patient has a U wave, they likely have hypokalemia. And then here's the other signs and symptoms, right? You got the little image here, and the only mnemonic I could find was sick Walt. All right, you figure that out. All right. Again, you're going to administer potassium supplements. If they're alert and oriented, it's probably going to be something oral. You are never, ever, ever going to give an IV bolus of potassium as part of the death penalty cocktail, okay? Do not give anyone IV push potassium. Do not inject potassium into the tissues. It could cause necrosis. If anyone's ever received IV potassium, it burns like heck. I never received it, but I've been yelled at enough times to know that it burns. So you don't want to administer any IV potassium in a small vein, in a small IV, in an area like your hand where it's going to be more sensitive. You want to put it in a big IV, up in the antecubital space or something, 20 gauge or higher. And then cardiac rhythm, I'm going to say it again, and dig toxicity. People with low potassium are going to be at risk for dig toxicity. This test, just like the last test, there will be a lot of food and diet questions in regards to electrolytes. So you do need to know that. Hyperkalemia, EKG change is going to be tall, peaked T waves, okay? Tall, peaked T waves. And then there's also YQRS. But the main thing, the peak T waves, you can actually do an EKG. I mean, I don't know, Pedro, how long you've been a paramedic, but usually when you put a patient on the monitor, you can see like, oh, I bet you they probably have hyperkalemia. You could see the peak T waves without knowing anything else. You could see it, and the doctor say, oh, let's get a potassium and mag level. So tall peak T waves. And then here's the other signs and symptoms. You can read about it, and we'll talk about this more. As far as causes, again, overconsumption, renal failure, patients on dialysis, that's the main thing you're looking at them, is that potassium level. People who have severely high potassium, even that don't, if they had an acute kidney failure, if their potassium's like 7, 6.5, they're gonna need dialysis because we got to get that potassium out of you quickly. Other things you might give, I'll tell you on the next page, diuretics or K-Exolate. But acidosis is another thing, and I'll show you why that causes hyperkalemia. And then tissue damage. Why? Because remember, potassium's inside the cells. So if I'm in a car accident with major crushing injuries to my legs and all this tissue damage, all these cells have been damaged, and all this potassium's just leaking out freely into the extracellular space. Nursing considerations, again, EKG, cardiac monitoring. You need to know, I put on here, page 288, just go in there and read about diet. I'm not a dietitian. Meds. Has anyone ever heard of giving insulin for high potassium? Insulin forces potassium into the cells. So when a patient's in the ER and they're coming in with high potassium, they're likely to get IV insulin, and it has nothing to do with diabetes. IV insulin, in the extracellular fluid is going to force potassium go back, get back where you belong, get back inside the cell, okay? And then remember, when we draw blood, we're only looking at extracellular fluid. So if all that potassium shifted back into the cells, then the results should go back down, right? Of course, if I'm going to give you IV insulin, I also got to make sure I don't kill you. So then you give them dextrose 50 with that. The dextrose is only to prevent low blood sugar after I just gave you all this insulin. Diuretics, furosemide, torsemide, loop diuretics. They reduce potassium. You should know that from pharmacology. When patients are on a loop diuretic, they're usually on a potassium supplement because those medications deplete your potassium levels. And then Kxalate. Kxalate works like lactulose, and it's just going to have you poop it all out. Calcium. I already told you about what calcium does. Here's some things that could cause hypocalcemia. Again, with the calcium, the main thing is monitoring for tetany. When you read your book, make sure you know Chvostek and Trousseau's signs. I'll show you on the magnesium thing, on the magnesium slide. But Chvostek and Trousseau's signs, they will be on your test. Hypocalcemia, obviously, administering calcium supplements. Vitamin D aids in the synthesis of calcium and absorption of calcium. So you're going to give them vitamin D supplements. If somebody has a vitamin D deficiency, they might have a low calcium. Because of the way calcium works, remember the risk is tetany. It can also cause them to be at risk for seizures, irritability, things like that, cellular irritability. So you want to keep keep the stimulation low. And then the foods, again, you just need to read about that. Know this stuff on the bottom as far as administering calcium and calcium gluconate, okay? You can read about that in your book. I'm trying to hurry up and get y'all out of here. I got like 3 slides left. Hypercalcemia mostly is just related to cancer. A lot of cancers and tumors can cause hypercalcemia. And it's not even a lot of it about hypercalcemia in your book, because most people, if they have an issue with calcium, it's going to be low. Magnesium. Oh, did I email myself the right PowerPoint? I don't know. But anyway, don't worry about it. Don't even worry about it. Don't trip. Magnesium, okay? Magnesium, again, remember on the slide about magnesium, it has to do with the skeletal muscles. So, only thing you gotta remember with magnesium is low magnesium is gonna cause all this hyperexcitability, and the muscles don't know how to react. So it sounds crazy, but low magnesium is gonna increase your DTR. So let me not kick my shoe off. But DTR, deep tendon reflex. When you go to the doctor and they hit you in the knee with the hammer, right? Or the karate chop you, whatever they do. If you have a low magnesium, it's gonna be exaggerated attack. You're gonna kick the doctor in the face, okay? It's going to cause the tetany, like hypocalcemia. Same with hypocalcemia. Hypocalcemia, hypomagnesemia pretty much look alike. Tetany, positive Trousseau's sign, positive Chvostek. Chvostek, if I tickle your cheek, you start twitching. The side of your mouth starts twitching. I can't do it because my calcium is good. Trousseau's, if I put a blood pressure cuff on your arm and tighten it up, your wrist is gonna lock up. Tetany, okay? Low magnesium causes tetany. also causes high blood pressure. Women with preeclampsia, what do they give them? Magnesium, right? So now let's talk about hypermagnesium. Hypermagnesium is going to be a little too relaxed and flaccid. Your DTRs are going to be decreased. I'm itching and then nothing is probably going to happen, or maybe a little something, but nothing, really, nothing. It's going to be everything to relax. So the number one concern, if all my muscles are relaxed, what do I need to be worried about? Respirations. My diaphragm is too relaxed. My diaphragm contracts and relaxes to allow, remember, skeletal muscle, not cardiac muscle for magnesium, skeletal muscle. So my diaphragm contracts and relaxes to allow my lungs to breathe. When a pregnant or a preeclamptic woman or a postpartum woman is getting IV magnesium, the main thing you need to watch them for is respiratory depression and monitor DTRs and make sure they're not just laid out, they're just too relaxed. So just remember with magnesium, it's the opposite. Hypomagnesium causes hyper muscles. Hypermagnesium causes hypo muscle function. Okay? Got it? Good? All right, and that's it. You don't really need to worry too much about chloride and phosphorus. Again, potential causes, changes you're gonna see. And I'm gonna email you guys this. I'll do acid base next week because I want you to be able to get a break. And then next week we'll talk about kidney function, and we'll do a lot of practice, review, looking at real patients and stuff. I don't really want to lecture that much next week because you really need to just see these situations and get some practice in. But please read a little bit, read some. Shavastic? Oh, it's definitely in your ATI. It's on, let me show you how you spell it. It's on this slide right here about hypomagnesemia. You see positive, Shavastic, and Trousseau sign. That's how you spell them. Okay. And that's in your okay, so I did dismiss the class, but I just want to go on with this lecture so that you guys all have access. So anyway, so causes of hypomagnesemia, like I said, a lot of it is GI. If you have issues, especially with the small intestines and malabsorption, if there's patients who have steatorrhea and that kind of stuff, it's usually going to lead to a low magnesium. Another interesting fact about magnesium, magnesium goes hand in hand with potassium. So if a patient has a low potassium, chances are they have a low magnesium. Again, hypomagnesemia, you're going to be looking for neuromuscular irritability and excitability. And hypermagnesemia, you're going to be looking for the opposite of that. Okay. Also, you may see changes on the EKG. Hello? Yes. Okay, and the clinical manifestations. So you'll see maybe EKG changes with low magnesium, again, hyperactive DTRs, maybe tingling numbness, paresthesia from, again, that neuromuscular excitability, irritability, tetany, which is that tightness, reflexivity, maybe that's a word, I don't know, of the hyperextension of the muscles. seizure activity could occur. Remember, positive Chavastex and positive Trousseau signs. You need to look those up. They are seen in hypomagnesemia as well as hypocalcemia. And again, hypocalcemia, hypomagnesemia all go together. So the symptoms will be similar with the depressed mood, the apathy, the agitation, right? Okay, sorry, I keep getting interrupted. Another thing I didn't mention up here, the ethanol ingestion. Alcohol abuse, alcohol intoxication, alcoholism leads to major excretion of magnesium. Magnesium is primarily excreted via the kidneys and urine. And it is also absorbed in the small bowel. So when there's issues with the small bowels or when you're having excess urine output, those things can cause a reduced magnesium level. Nursing considerations. So again, you want to correct the concurrent imbalances of such as potassium and calcium. Encourage, usually dark green leafy vegetables are going to be highest in magnesium. You're going to discontinue any meds like loop diuretics. Anything that makes you pee a lot is going to make you lose magnesium faster. And then administering magnesium. Of course, if you're administering IV magnesium, again, you need to watch for those signs of hypermagnesemia, which is going to be totally relaxed muscles. They're going to have decreased DTRs. They're going to be at risk for respiratory depression. And then again, magnesium and potassium go hand in hand. So low magnesium probably means low potassium, which is going to increase your risk for digitalis and toxicity. Sorry. And again, calcium gluconate works with the heart. So if they have hypermagnesemia, then you would administer calcium gluconate to reverse that. Finally, let's just talk briefly about acid-base balance, right? Acid-base balance. When we look at acid-base, we're looking at, and your levels, we're looking at pH, right? pH. It is obtained from an arterial blood draw. We draw blood from the artery, usually the radial artery. An arterial blood draw, an arterial pH is an indirect measurement of hydrogen concentrations. Hydrogen is an acidic substance, and high levels of hydrogen in the extracellular fluid is going to create acidosis, right? pH is a balance. It's created by a balance of CO2, carbon dioxide, CO2, which is controlled by the lungs, right? So issues affecting the lungs will ultimately affect our CO2 levels, which could either increase or decrease hydrogen in the body. Bicarbonate, remember, is a main electrolyte we see outside of the cells, and it is controlled through the kidneys mostly. Kidneys work to excrete and absorb bicarbonate, HCO3. Anything affecting the kidneys could essentially affect bicarbonate and then therefore affect our pH. When we talked about potassium before, I told you potassium is affected by acidosis because what happens is Potassium moves in and out of the cells in exchange for hydrogen ions. Remember, we're drawing blood from outside of cells. So when we're checking pH and the pH is low, it is because there is a high concentration of hydrogen circulating. High concentration of hydrogen circulating. And that is going to cause a low pH and therefore acidosis. Acidosis is going to, for our body to try to correct it, what we're going to do is try to push potassium out of the cells and force hydrogen into the cells, thus lowering the amount of circulating hydrogen in the extracellular fluid, increasing pH, right? Trying to get us out of this acidotic state. But at the same time, it's going to increase our serum potassium levels and lead to hyperkalemia. Vice versa, hyperkalemia, hydrogen may move out of the cells in exchange for potassium to lower the potassium, but in exchange, it's going to cause what? Acidosis, right? And now hypokalemia. When we have low, I'm sorry, I say hyper, right? Yeah, hypokalemia, we're going to have potassium. What results from this is hydrogen has now come out in exchange for potassium, but now it's leaving us hypokalemic, right? It's going to cause potassium to go down, potassium levels to go down. And again, this is if the body was alkalotic. So if it was alkalotic and we had low hydrogen outside the cell, hydrogen is going to move out of the cells and force potassium into the cells. Hopefully everyone understands this. So let's talk about different imbalances, right? And let's talk about it like this. If it affects CO2, which is controlled by the lungs, then we know it's a respiratory issue. And if it affects HCO3, bicarb, which is controlled by the kidneys. Think about it. The kidneys play an important role in metabolism, right? Metabolizes drugs and substances and allows us to excrete and reabsorb substances and water. So anything having to do with bicarb or HCO3, which is controlled by the kidneys, which their main job is a role in metabolism, is going to be metabolic. So let's talk about metabolic acidosis. Metabolic acidosis is going to be due to a low bicarb. Bicarb is a buffer. It is basic. It's basic, okay? So when we have low bicarb, then we're going to have a high amount of hydrogen ions circulating in the ECF, and we are going to have a low pH. So in metabolic acidosis, the pH goes down and the bicarb goes up, okay? They're inverted. pH goes down, bicarb goes up. If you look at that ABG quick interpretation cheat sheet thing I gave you, you'll see how the arrows move. Metabolic acidosis, pH goes down and bicarb goes up. Things that could cause this, DKA, diabetic ketoacidosis. That diabetes is a metabolic disorder and it already tells you it's acidosis. So DKA, severe diarrhea, because in severe diarrhea, you're losing a lot of bicarb. And because of that, you are at risk for acidosis. You've lost bicarb. I wouldn't worry so much about renal failure because renal failure, I'm sorry, you would definitely know renal failure. Renal failure is probably the number one cause of metabolic acidosis, because one, the kidneys are unable to excrete any bicarb, right? Or absorb any bicarb. I mean, they just have no control. The kidneys have failed, okay? So they can't absorb, they can't control absorption and excretion of bicarb. Another cause, a major cause is shock, and more specifically, sepsis. Sepsis causes lactic acidosis, okay? Sepsis is a cause of metabolic acidosis. So sepsis, kidney failure, diarrhea. Those are the main things that cause, and DKA, that cause metabolic acidosis. So when we look at the symptoms are going to be basically our body trying to compensate, right? So hyperkalemia, remember I showed you, potassium is going to come out of the cells here in the pink. Potassium is going to come out of the cells to get hydrogen in the cells. So it's going to cause hyperkalemia. May cause some muscle twitching because that's what hyperkalemia causes. They may have low blood pressure, headaches. But the main thing, hyperventilation. They're going to be breathing fast, okay? Trying to blow off as much CO2 as possible. Why? Because if the metabolic system is not doing its part, now the lungs got to step in and help out. So this is how you end up with compensated, partially compensated ABGs, right? The CO2, the body's going to try to lower CO2 to compensate for that lack of buffer, the lack of bicarb, okay? So a patient with acidosis is going to be hyperventilating, trying to blow off as much CO2 as possible. Alkalosis. Metabolic alkalosis is going to be a pH greater than 7.5, and a bicarb greater than 28. So in metabolic alkalosis, pH is going to be up and bicarb is going to be up. With that, so metabolic, remember, bicarb and pH move in the same direction. So metabolic acidosis, pH is down, bicarb is down. Metabolic alkalosis, pH is up, bicarb is up, okay? Signs and symptoms. Again, the main thing, you're going to look at hypoventilation. So if the bicarb is high and everything is super basic and alkalotic, my body is going to try to compensate and retain CO2. So I'm going to have hypoventilation. I'm going to be breathing much slower and shallower to try to hold on to some CO2 to balance out this pH. Causes would be anything that's going to reduce the metabolic acid would be like, especially GI suction. When you put that NG tube in and you're sucking out all the gastric acid, now they're going to be at risk for metabolic alkalosis. Any thing that will cause excessive bicarb, sodium bicarb, like taking sodium bicarb. Maybe they're in the hospital and they're getting IV bicarb for some reason. Maybe they were acidotic before and now we've over medicated them with bicarb. But excessive GI suction and vomiting, anything like getting rid of that stomach acid, vomiting, and GI suction are going to be your main culprits. Also excessive use of antacids. Excessive antacid use. Why? Because it's going against the acid, right? Antacid use is going, so if you took a whole bottle of Tums, you're going to be at risk for metabolic alkalosis. And again, now the potassium is going to go down because potassium is going to move from extracellular fluid into the cells to help get more hydrogen out. 2 more slides and then we're done. Respiratory acidosis. Now we're talking about the lungs. Respiratory acidosis is going to be caused by retention of carbon dioxide. So people with COPD, especially COPD, are CO2 retainers, okay? They have a harder time blowing off CO2. They're at high risk for respiratory acidosis. Because of that, we teach them to tripod position and pursed lip breathe. Pursed lip breathing increases the amount of air we're exhaling and gets more, helps us force more CO2 out of the body. Hypoventilation is what's going to cause us to retain CO2. So for example, a heroin overdose, opiate overdose, anything that causes hypoventilation is going to also put us at risk for increased CO2. If my respirations are slow and shallow, I'm not breathing off enough CO2. So anything with lung disease and opiate overdose are going to be the main culprits of retained CO2. And then you see the different signs and symptoms, okay? Finally, respiratory alkalosis. This is going to be people who blew off too much CO2. Hyperventilation. Hyperventilation, like in a panic attack, when people are breathing too rapid and breathing, deep and rapid, they're freaking out and having an anxiety attack. Or if you've ever had an anxiety attack, one thing those people commonly complain of is numbness and tingling in their hands and feet, or, after they're having this anxiety attack and they've been hyperventilating. That's signs and symptoms of respiratory alkalosis, okay? Numbness and tingling in the extremities, right? Mechanical ventilation, if they're on a ventilator and our settings aren't proper and we're giving them too much ventilation, then we could cause them to get rid of too much CO2 and cause respiratory alkalosis. So with this one, you see pH goes up, but that's because CO2 went down. So CO2 and pH have an inverted relationship when it's respiratory related. And that's it for now. We will talk about kidneys and urinary tract next week. However, I do want to show you guys one more thing, and then I will give you a break. But I would like to, oh boy, let me open this email. I'm just trying to find this ABG tic-tac-toe. I'm posting this in Moodle. And I would like everyone to start looking at this and considering this, okay? We went over it with the Tuesday night class, but not everybody got a chance, right? So I'm posting this in Moodle and we'll do some more together as a group next week. There's plenty of videos online. Nurse Sarah, everybody loves her. She even has a video about this ABG tic-tac-toe, all right? So I want you to learn how to do this method because this will help you interpret a lot of ABGs, right? If you set up a tic-tac-toe, everybody should know how to play tic-tac-toe. You got your lines here. Uh-oh, hold on, I didn't pull it up. Let me share the screen with you. I apologize. All right. So now you should be able to see my screen here. So when you set up tic-tac-toe, everybody knows how to do this. You got two horizontal lines and two vertical lines and two horizontal lines. I'm going to give you a freebie, and the first row will already be filled in. And this is how you fill it in. One side acidosis, one side alkalosis, and down the middle we'll have normal. Now, as you look at these values, you're going to plug in pH, CO2, and HCO3. So let's draw. All right. So let me use this marker. This will be like my whiteboard, right? So let's do this first one so I can give you a good example. The pH is 7.53. A normal pH is 7.35 to 7.45, right? This pH is greater than 7.45. So I know pH is alkalotic. So let me just write pH here, right? pH, alkalosis. So now I got two in a row here. PCO2 is 44. A normal PCO2 is 35 to 45. So I know 44 is normal. So I'm going to put CO2 here. Now, bicarb, 34. According to ATI, a normal bicarb is 21 to 28. Okay, so 34 is greater than 28, and a high bicarb is going to make the patient alkalotic. So HCO3 is going to go here, right? So now I have tic-tac-toe 3 in a row, right? It is alkalosis based on the pH. And now, because I know it involved the bicarb, I know that's controlled by the kidneys, and thus this is a metabolic issue. Therefore, the patient has metabolic alkalosis. Hopefully everybody got that. One more. pH 6.97. Normal pH is 7.35 to 7.45. Obviously, 6.97 is much less. A low pH is going to be acidotic. CO2, 35 to 45. This CO2 is high. A high CO2 is going to be acidotic. Bicarb, 21 to 28, 27 is normal. So I'm just going to slide that right on in here, right? So tic-tac-toe, 3 in a row. I have acidosis. I know that by looking at the pH. It involves CO2, which is controlled by the lungs. Therefore, my patient has respiratory acidosis. So you guys can look up more values to help you complete this. I do have a list. I'm posting this here in Moodle, so you guys can do that. There's an example again on the bottom with this patient here who had the pH of 7.25, the CO2 of 60. PO2 may be another value. I remember Donna in my night class asked about that fourth value. PO2 is just looking at the arterial oxygen. Normal is actually 80 to 100. You don't need to know that for this exam. And it has it's not part of the acid-base balance. But likely, if their PO2 is low, their PCO2 is going to be high. So this person likely, we already knew, had a respiratory issue, right? And then the bicarb is 26. So when we look at this here, even though I didn't add bicarb technically would have went here, right? In the normal. I forgot to put that down here. But anyway, the pH was 7.25 less, so that's acidotic, and then the CO2 was high, so that will make it respiratory acidosis. This patient was found down, likely due to a heroin overdose. But anyway, those are just some examples. I hope this lecture and this activity helps you guys. And next week, we will talk more about kidneys, acid-base balance, and we'll do a lot of practicing together. So I hope all this helps. Please reach out if you need any help, or if you want to schedule some tutoring or anything.